Last but not least, from Speech, Language, and Audiology Canada, we have Chantal Kealey, Director of Audiology, and Meredith Wright, Director of Speech, Language, Pathology, and Communication Health Assistant. Welcome, and the next 7 minutes are yours.
Thank you, Mr. Chair, for the opportunity to address this important committee. I am proud to represent Speech, Language, and Audiology Canada, the National Professional Association for two distinct but interconnected professions of speech-language pathology and audiology. Today, the association represents approximately 6,400 professionals across Canada. My name is Meredith Wright, and I'm joined today by my colleague Chantal Kealey. As a speech-language pathologist, my scope of practice with seniors includes assessing and treating a wide range of communication and swallowing disorders, from the inability to communicate following stroke to swallowing difficulties experienced by a person with dementia at the end of life. As an audiologist, Dr. Kealey's scope of practice with seniors includes assessing and treating an array of auditory disorders such as hearing loss, tinnitus, auditory processing, as well as balance problems. The term communication health for our association refers to everything within the scopes of practice of audiology and speech-language pathology. We know that the existence and extent of most communication and hearing difficulties is largely unknown by the Canadian public. But the statistics are eye-opening. Approximately 1 in 6 people in Canada has a speech, language, or hearing disorder. As we age, we experience a decline in memory, and our ability to process information slows. Complex sentences, like the ones used by many healthcare providers, lawyers, and financial planners, become more and more difficult to understand. Aging muscles can contribute to the development of swallowing problems, particularly in frail seniors, and swallowing problems can result in choking, malnutrition, dehydration, and pneumonia. Hearing loss also gradually increases as we age. By 65, about 1 in 3 people has a clinically significant hearing loss, and by 75, about 50% of people are affected. Seniors are by no means a homogeneous group, but certain changes in communication, swallowing, and hearing abilities are associated with normal aging, so even the healthiest of seniors need access to affordable and appropriate care as they age, so that they are able to have a high quality of life and stay in their homes as long as possible. However, more significant communication, swallowing, and hearing changes can occur as part of an age-related health problem. With aging comes a higher prevalence of neurological conditions such as stroke, Parkinson's disease, Alzheimer's disease, and other dementias. Communication difficulties experienced by people with neurological diseases vary depending on the type and duration of the disease and the part of the brain affected. For instance, people who've had a stroke may experience both communication and swallowing difficulties. People with Parkinson's disease may have speech and voice problems. The relationship between hearing loss and dementia is receiving significant attention. Research suggests that hearing loss is more prevalent in seniors with dementia than in those with normal cognition. Indeed, some studies found that individuals with hearing loss had 2 to 5 times increased risk of developing dementia, although we should not assume a causal link at this time. Furthermore, hearing loss, especially if not managed appropriately, can lead to balance disorders, which increases the risk of falls. The risk of falling is 3 to 4 times higher amongst older people with balance disorders, and falls are the leading cause of injuries in seniors. Communication, swallowing, and hearing difficulties can be extremely frustrating, frightening, and isolating for the person experiencing the difficulties, as well as for their families, friends, and caregivers. Quality of life and personal relationships can be affected. Social withdrawal, anxiety, and depression can result. Caregiver burden can increase. Indeed, seniors with communication and hearing disorders may experience difficulty participating in many of social interactions of day-to-day life. Even accessing basic goods and services can be a challenge. Right now, we have an opportunity to build a better Canada for our seniors, one that includes universal access to appropriate communication health services. We need better training for service providers so that they can communicate with seniors in more meaningful ways. Service providers who work in places like Service Canada, hospitals, banks, pharmacies, and law firms need to be prepared to communicate with seniors who may not be able to hear and speak the way I do. For that reason, we need the new federal accessibility law to be inclusive of Canadians who have communication and hearing difficulties. We need to invest in more publicly funded community-based health services, including communication groups for people with hearing loss, stroke, Parkinson's disease, and dementia, and also communication skills training for family and caregivers. We need more community-based screening programs for hearing, balance, and swallowing disorders to ensure that seniors, particularly those living in rural and remote communities, are getting access to appropriate care in a timely manner. Too often we hear about publicly funded speech-language pathology and audiology positions being cut. This is deeply concerning since most Canadian seniors cannot afford to pay for private speech-language pathology and audiology services. We need to invest in more research as it relates to seniors and communication health to ensure Canadian seniors are provided with the best care. Audiology and speech-language pathology researchers in Canada make substantial contributions to the evidence base for the care of seniors with communication difficulties and hearing loss. We need to continue to support research focused on communication health in seniors. In conclusion, I urge this committee to consider these recommendations when developing its report and ensure the needs of seniors with communication and hearing difficulties are represented. Thank you very much.
Right, quickly, I know that accessing your services is getting harder for seniors. And I also know that speech and hearing issues can be mistaken for dementia, and often people are wrongly diagnosed. Could you just tell us a little bit about the impact of that?
Mm-hmm. Chantal, do you want to answer that around hearing issues first to start with?
Certainly.
Yeah.
So in terms of hearing loss and dementia, as Meredith stated earlier, people with hearing loss are at greater risk for dementia. So there is a lot of evidence showing this association. We at this time cannot determine any causal link, so it's very important that we understand that there is no cause and effect as of yet, just a strong correlation. And in terms of that, it's really people with hearing loss that are expending a lot of their efforts and energies to listen and listen meaningfully, especially in noisy environments. So they're doing these tasks that take a lot of cognitive load at the detriment of other tasks like working memory. So they're essentially consistently channeling their efforts to listen, effortful listening, and it's showing that there could be some changes in brain connectivity where these other pathways are being weakened, if you will.
Thank you.
So there's that association.
Can I add a bit about speech?
Very brief, please.
Also, just a number of communication disorders, say, related to Parkinson's disease and stroke. When a patient has communication disorders associated with those diseases, their intelligence usually is not impacted, but because they have communication disorders, it may be perceived by caregivers or service providers that they are less intelligent than they actually are.
Thank you.
Chantal, I've seen you at work. I saw you speak to my father to look for that brain connectivity. As you know, with a hearing loss, we have to be very aware of those things and what can carry forward. Are there any federal programs, or is there anything that we can do more, in effect, to educate seniors about their overall health when it comes to the hearing, when it comes to the speech pathology and dementia? Is there something that we can do at the federal level that we can help promote through public health?
Well, I think that that public awareness is a huge, a very important factor. I think that when we think of early detection and intervention, we often think of children or babies, but we also need to be looking at our healthy adults and ensuring that they understand the importance of early identification and intervention of hearing loss. So right now, it takes people about 7 to 10 years to seek help when from the time they first notice a hearing impairment. And, you know, there's a lot of damage that can be done in that time. Mm-hmm. And what is important is the earlier that you do suspect a hearing loss, you should be going for help. And we need to be educating the public about that. Mm-hmm. Certainly with senior-related hearing loss, The typical intervention would be hearing aids, but that's not the only intervention that's out there as an option. But in terms of wearing hearing aids, the earlier that you start that, the more acclimated you become, the more that your brain then relearns to hear all these sounds you haven't heard. We find that with the elderly, hearing aid acceptance goes down tremendously when they can't manipulate the hearing aid. So when you start a little bit earlier, you become a little more accustomed to all of that. It doesn't mean that you're not going to have dexterity issues when you get a little bit older, but when dexterity and vision start to be compromised, it becomes even more difficult. So if an 80-year-old is starting to wear hearing aids for the first time, it's much more difficult, and they've lost a significant amount of time of auditory input. And that deprivation is what also leads people to withdraw and to become isolated. So hearing aids has been shown to correlate to less feelings of loneliness, but also lower scores on depression scales. So I think public awareness is very important.
Absolutely. Meredith, do you have anything to add on that?
Also, I think the federal government can be a leader in ensuring communicative access for people with hearing and communication disorders through the new federal legislation around accessibility, and also be a leader, say, within Service Canada and the other government departments to enable people with communication disorders and hearing disorders to be able to access those services. Also, the federal government's new funding for home care and community care. Performance indicators, including how much money is spent on speech-language pathology and audiology services, would give us an idea, province by province, how much is being spent, sort of like a report card, so we know where the funding is going and whether it is potentially getting to people with communication and hearing issues.
Thank you. So I'm going to come back to you, Ms. Wright. The Speech and Language and Audiology Canada was part of the Alliance for a National Senior Strategy. Can you share with us specifically what your organization would like to see happen in this strategy and what the next steps should be for this government?
My discussion will relate mostly always to speech-language pathology and audiology services. As Dr. Marcoux has mentioned, the acute care hospitals have been primarily the place where care has been provided. But now that we have a changing healthcare system, with positions being cut in hospitals, beds also being cut, we need to be developing the community services. So our organization is very much focused on looking to see what services can be provided in the community and through home care for our patients and elderly seniors. So we need services in place to maintain people who are relatively high functioning but say are developing hearing loss. We need access to services that those individuals can afford to pay for. Private speech-language pathology, private audiology services don't come cheap. Not all seniors, especially those on low and fixed incomes, can afford them. So we would need access to publicly funded services for that particular group. We also need to ensure, as part of a senior strategy, that there's appropriate community and health care for those ill, frail seniors, people with neurological disorders, to help them manage in the best way that they can. So we need to have those services in place, but we also need to make sure that they link with other services, that they link with the family health care team, they link with other social services as well. We have pockets of excellence in service providing in the community, and I'm thinking locally the Aphasia Centre of Ottawa, which provides community-based services for people following stroke and follows them for years afterwards, and it's a collaborative approach with social worker. These services are available in the city, but not necessarily available in rural and remote communities, and not necessarily available across all provinces. So I'd like to see that we look for examples of excellence, not only in clinical practice, but also look at the current research that's happening in our professions, audiology and speech-language pathology. We have leaders in research in dementia and various other forms of degenerative conditions, developing different sorts of intervention strategies with caregivers and with people with dementia and other degenerative conditions. I'd like to be able to see that those programs that they've developed are actually translated into practice as well.
I also know that your organization supports the revising of definitions, terminology, and requirements for the disability tax credit. Can you tell us how the current interpretation isn't working?
I'll let Chantal answer.
Well, for the hearing portion of the disability tax credit, the language in there is very ambiguous, and audiologists find themselves often wondering if they should be certifying this individual. The language in there basically states that someone needs to be, are they markedly restricted in an environment that's quiet with somebody they know? And the problem with that is we don't live in a quiet environment, only speaking to people we know. So that language really does need to be changed, and that will then, I think, provide a little bit more assurance that the audiologist or the physician or nurse practitioner who can certify certain parts of the disability tax credit, they're doing the right thing, and they're basically helping their client when it's necessary. We do find that anecdotally, I've heard from a number of people that patients do a little bit of shopping around to see who will actually sign this for them, because a lot of people just don't feel comfortable when they have to use those that criteria.
Yeah, thank you.